Now, Executive Suites with WPRI.com reporter Ted Nesi.
Welcome to Executive Suite. I'm Ted Nesi, and we're talking today with one of the most familiar names in Rhode Island business, their leader. We're talking about Blue Cross and Blue Shield of Rhode Island and the world of health insurance and health care. It's all changing rapidly, and we're going to talk with a woman who knows a lot about it, and that is the president and CEO of Blue Cross, Kim Keck. Kim, thanks for being here.
Great to be here.
Get blue in my head when we're talking Blue Cross. Kim, I want to start off with people, I find when I write about Blue Cross, people don't always understand, kind of, because there's a Blue Cross in Massachusetts, there's Blue Crosses in other states, kind of how that relationship works between all the things with the Shield. Can you briefly explain that to folks?
Absolutely. So Blue Cross Blue Shield of Rhode Island is a local, independent, and not-for-profit health plan that's singularly focused on Rhode Island. We're part of a national association, if you will, that has 36 independent, not-for-profit Blue plans. There's also a for-profit Blue plan called Anthem. And Anthem is actually one state away from us in Connecticut. It's also in Maine. But most of the New England states are the local, not-for-profit, independent as we are.
So you have a relationship with each other. You all use the Shield and everything, but
Yes.
you run it independently.
Yeah, we have what's called a marketing area that we are exclusively servicing Rhode Island. And so no other Blue plan services Rhode Island but for us.
Okay, and I think it's important for people to understand as we go in. So you took over at Blue Cross in 2016. Actually, after a lengthy career at another well-known insurer, Aetna. You spent a number of years at Aetna. I'm curious, what appealed to you about Blue Cross Rhode Island and this job? Why did you decide to take this?
So I was at Aetna for a long, long time. I went to Aetna a lifetime ago and expected to stay for 2 years. Actually, I found it interesting when I was interviewing there in the maybe late 80s. A lot of the people that I interviewed with had been there for like 20, 25 years. And I went home and told my then new husband, still now husband of 30 years, that these people had been there forever. And I was like, that's sort of weird. And I found myself being one of those people because there were so many interesting things to do. And I mostly did kind of financial roles and really actually started in investment management and didn't actually make my way to the business side of things until maybe the last 10 or so years. But holistically, what I found, Ted, is at Aetna was great company, great opportunities. But it was likely in many situations I found myself kind of what I call an inch deep and a mile wide. And so I happened to meet Peter A. few years ago. And
your predecessor. My
predecessor at Blue Cross. And we know a lot of the same people, and we just kind of were networking just to connect on business issues. And, so I started to get interested in what a single state Blue plan could be. I happened to be from Rhode Island. I grew up in Rhode Island. I owned a home in Rhode Island at the time and thought, wow, this would be a great place to come back when the opportunity presented itself, to come back and have a real impact, to go kind of that not just inch deep, but mile deep, and really have an impact on healthcare in Rhode Island, but also on the community. What was missing in my prior life was this kind of community focus that is a huge component of who Blue Cross is here. So it's the real opportunity to have an impact and make a difference in our state. And that's what made it so attractive.
So, no secret, there have been a lot of changes in healthcare, health insurance in recent years, not always the easiest business to be in, especially lately. I'm curious, when you took over, kind of looked through, all the reports, transition stuff, got briefed, all that, what did you see as the biggest challenge Blue Cross faced when you took over about 2 years ago now, and that you knew you'd be spending a lot of time on?
Well, if I thought really, really short term, when I came in June of 2016, the first 6 months of that year, Blue Cross had lost $50 million.
Yeah.
So my first and immediate thought was, okay, well, let's at least mitigate the losses that we were experiencing and, put ourselves in a financial position to really do the kinds of work that we want to do, both in the community and from our business perspective. And so in the second half of 2016, we made about $15 million. So first and foremost, kind of myopically said, okay, let's, understand what we're doing with respect to why we have so many losses, which were largely a lot of services being used, which I can talk about in a second. But then more futuristically thinking about, we have a great opportunity to transform the way we pay for healthcare in this state, the way we use healthcare in this state. And my predecessor, Peter A., and the team did a lot to kind of set the foundation for that. But I think, we had to do some things to get our losses more under control, which we did quickly, so we could build off the foundation that had been built on transforming care in the state. And
you actually turned it around fast enough. 2017, actually, you were in the black again after a couple of years. You folks had been in the red at Blue Cross. How is, we're in May of 2018, how is this year looking for you?
We just actually disclosed our first quarter results. There's an operating loss, but the operating loss is all due to timing with respect to how the Affordable Care Act, which is the national health care reform law, that's, 8.5 years old now. The way certain technical components of it work, you pay the taxes, which are pretty substantial, in the first quarter.
Yeah, I've learned from the quarterlies can be misleading.
So the year will be fine, although in healthcare it's a really funny business. We're actually setting our prices as we sit here in May of 2018 for all of 2019.
Yeah.
It's a really funny business. There's very few businesses where you don't really know your cost of goods sold, when you're actually pricing how much your product is going to cost. So in any case, 2018 looks fine so far. We had a little bit of uptick in the flu in the February-ish timeframe, but so far so good, except we often have surprises in this business because, again, we can't always predict who's going to have the next knee replacement or who's going to have the next $1 million drug, for example.
Yeah, and if that comes up, you have to cover it generally, right? If someone invents something.
I mean, there are parameters, medical policy and pharmacist policy. We have a therapeutic committee that's actually made of pharmacists and physicians, and in many instances physicians, that determine the kind of rules, if you will. So it's not just if something is invented, it's automatically under your policy, but nonetheless, there are large group of drugs that are very expensive. It used to be that a $10,000, $20,000 drug was expensive, and now we're approaching almost $1 million for certain drugs.
It's an astonishing amount of money for some of these drugs. You mentioned the Affordable Care Act. I want to ask you about that. We had the big changes that law put in place in 2010 and the rollout of that in the coming years. Then 2017, we had the big debate over repealing or replacing it. That didn't go through, and so now we're sort of in an in-between where the current administration doesn't love it, but it's still the law of the land. What are your current concerns on federal policy when it gets down to past all the fighting in Washington to how you run people's health insurance day to day?
Sure. It's a good question, Ted. So much of what has been debated about the Affordable Care Act in Washington is really, in many respects, been left to the states to determine how to implement, not all of it, but much of it. So there are certain provisions that are still the law of the land, but there are certain things that Rhode Island has actually been proactive in actually instituting or in the process of incorporating into state law to ensure protections. So things like insurance can't, which I actually think is good policy, and I don't know that Blue Cross ever acted this way, but insurers can't underwrite based on a pre-existing condition, right? So that will be, if it's not already, and I should know this, but it's just escaping me right this second, already incorporated into Rhode Island law. Things like keeping children on up to age 26 on their parents' plan. Things about how much you can rate for age, the age of the population, how much you can rate up for that. So there are certain aspects of the Affordable Care Act that are being built into already or in the process of being into Rhode Island law. So a lot of the rhetoric in Washington is not necessarily impacting us except for funding, which is not a trivial issue.
Yeah.
So on HealthSource Rhode Island, which is our public exchange that exists, a state-based exchange in the state of Rhode Island where individuals buy their own coverage, there are premium tax credits that are afforded to moderately income people that are provided by the federal government that make that health care more affordable. The federal government has taken away some of the subsidies, a specific cost-sharing reduction subsidy in 2017, which has made it more challenging to have affordable premiums because that was a component of keeping the prices low. So the general construct should be okay, but there's this question of without subsidies, which right now there's no more real concern that they go away, but it's hard to predict Washington, as we all know. You know better than I. But right now the state is really trying to step up. There's been a group formed here in the state. That's a cross-section of many different entities to think about the whole market stabilization that would impact just Rhode Island, and looking at different alternatives to ensure we have a viable market.
All right, when we come back, we're going to talk more with Kim Keck, President and CEO of Blue Cross, about why insurance premiums are higher than people want them to be and what might be done about that. Stick with us on Executive Suite. Welcome back to Executive Suite. I'm Ted Nisi, and we are talking today about one of our favorite topics in this show, the business of healthcare and how it affects all of you, as well as bigger market forces in Rhode Island. We're talking with someone who knows that world very well, Kim Keck. She is the president and CEO of Blue Cross and Blue Shield of Rhode Island. And Kim, we were talking before the break about costs and the Affordable Care Act and all the craziness going on in Washington. But, you know, for folks at home, what they end up thinking about is, what's my premium? What's my deductible? The brass tacks of health insurance. And whenever I do a story about health insurance in Rhode Island, you inevitably get comments from viewers saying, I just wish it wasn't so expensive. Right. Sometimes they mean the premium, sometimes they mean the deductible, sometimes they mean both. And there are states where health insurance appears to be cheaper than Rhode Island. Why is Rhode Island a more expensive state for health insurance? I know it's a big question, but...
Sure. So first of all, just why are health insurance premiums so expensive, right? Health insurance premiums are driven by healthcare costs. And so in many respects, the question is, why does it cost so much, right? And I think about simplistically two kind of buckets that drive costs. First, there's the unit cost, which is kind of the price per service, right? And then there's utilization, or the number of services used. In many places in the country, unit costs drive healthcare costs. Here in Rhode Island, it's a little bit of both. We have some unit cost challenges for sure, but utilization, the amount of services provided, is really high.
I remember Peter A., your predecessor, you talked about that too when he was on the show, about Rhode Island people just using healthcare services more.
They do. First of all, we're older, and typically older people do use more services, but even in our what we call our commercial population, right, not just the Medicare that is 65 and older, but in our commercial population, we see the average Rhode Islanders in our book go to specialists at a rate that's like 136% to be precise, higher than benchmarks I'm used to, even looking to our neighboring states. So it's a big, kind of almost a culture here that we seek a lot of services. And so one of the things that we're doing at Blue Cross is certainly educating our members on services, what's appropriate, what's not. It's really hard to do, especially if you're us. But we're looking to the academics. There was a health affairs article, for example, that was recently published, and something that is trending a little bit hard to implement, but this notion of low value care. And what this health affairs article suggested is that about 20% of care that's delivered is low value, meaning you and I would say, for example, see no value in getting tested for a vitamin D deficiency, because it turns out in the Northeast, probably all of us have a vitamin D deficiency. But we're not going to necessarily treat it or do anything differently. And yet we see a lot of vitamin D tests, for example. Imaging and diagnostic testing before low-risk surgery might be another category where there's a routine of getting everything scanned before a low-risk surgery. And you know, physicians and academics need to understand, is that really adding to
Because in the end, most of us are going to just follow. If the doctor says to get these, I march every year out of my physical and go do the blood test. They told me I don't even ask whether it's just, she said I do it, I do it.
Well, and that's part of the cultural interesting component of Rhode Island, I'll say, right? So it's not just culture from the patients, it's some culture from the providers. It's just kind of how we practice. And as you know, or you might not know, but healthcare is hyper local. So we can have a culture of how healthcare is delivered in Rhode Island that looks markedly different from, you know, someplace 90 miles away.
Is there low-hanging fruit in Rhode Island, do you think the state could do that would make a measurable impact on premiums that maybe other states are doing? Or?
I mean, there's some work that could, on the margins, help. I don't think that there's a nugget that's going to say, let's take out the next, you know, big chunk. There are things like, in every state, right, how we, as insurers, can think about how wide a network do we want to have. In Rhode Island, that's another kind of driver of cost, is this expectation that we have every physician and every hospital, for example, in every product. And Blue Cross has been, prior to my time here, working on trying to give our members or customers' choice to say, you can have that product, but you can also save yourself some premium dollars and have something that doesn't include everything.
You actually have a new one with Lifespan, the big hospital group, Blue Chip Direct Advance. You introduced it last year, and it's something's called a narrower network or something like that. Where I presume if you take that, you need to go to Lifespan doctors. Can't necessarily go to like a Care New England doctor, but you can pay less.
There's a wraparound network of physicians that you can see, but it's not every physician in the state, as some of our products may be, and that's exactly the concept, Ted. Right? Is how to get partnering with Lifespan to say, look, we want to provide a more affordable product, particularly the people who are paying themselves and have no help from their employer. They might get some subsidy from the federal government, but how do they, what are the ways in which we can make it more affordable? So, finding the high quality physicians that'll practice in a way that will help us produce a meaningful
What's been the reaction to that?
We've had good uptake. We actually had significant sales in the fall of last year. The way that product works, there's an open enrollment period in the fall, and that was exceeded our expectations.
Yeah.
So I think we need to do more of that.
Yeah, so people are price conscious.
They are.
Yeah, if you can make a difference on that piece of it.
Absolutely.
We're going to take a break. When we come back, we're going to talk about hospital consolidation and what's going to be happening to the future of our facilities in Rhode Island, as well as the big CVS Aetna merger. So stick with us on Executive Suite. Welcome back to Executive Suite. I'm Ted Nisi, and we are talking about the business of healthcare with the president and CEO of Blue Cross and Blue Shield of Rhode Island, Kim Keck. And Kim, like I said, we could do 2 hours on healthcare in Rhode Island. There's so much going on. But I have to ask you about the big debate raging about the future of the state's hospitals. You have Care New England potentially merging with Partners. You have Charter Care trying to checkmate that. Maybe they want to reopen Memorial. All this stuff happening. But one of the things that's coming up a lot with the Partners transaction is, will it drive up the cost of health insurance and healthcare around? Will this big Massachusetts company, if they have the Care New England hospitals, which is Women and Infants, Kent and Butler, be able to kind of up prices? You're the one who's going to have to pay them if they come in here. What's your thinking right now?
Well, the reality is we may all have to pay it. But here's what I would say, right? And there's not a lot I really can say, except I go to experts who might already have an opinion on this. So in the state of Massachusetts, there are a couple of state-based agencies that study consolidation and cost in Massachusetts. So there's the Health Policy Commission, and then there's a group called the Center for Health Information and Analysis. CHIA is the acronym. And in Massachusetts, CHIA has studied both consolidation and costs. And so I'm just going to use their work as illustrative, right, of things we might want to consider. CHIA has said in Massachusetts, first of all, it's the second most expensive state for healthcare costs in the country. I think second only to Alaska. It's not something Rhode Island is ranked as highly on. Unfortunately, we're still in the top 10, but Massachusetts, number 2 in the country. Partners within a very expensive state has costs that are about 40% higher than the average system in the state. 35% higher, and their flagship system is about 40% higher. They have 2 flagship hospitals, Brigham and Women, as well as Mass General. CHIA says these are expensive places for medicine to occur. CHIA also publishes that about 30% of the time, care that's delivered in one of the partners' hospitals could be done in a lower cost community hospital. That's available for anybody to read. Here in the state of Rhode Island, the state, in fact, hired a consultant, Baylett Health, I believe they call themselves, to at least do a cursory analysis of what the partners' entry into Rhode Island could be. And I think Baylett's work pointed at 2 potential drivers of cost. 2 things. One was consolidation of physician groups. One of the things that Partners has done in the state of Massachusetts is purchase a lot of physician groups and kind of bring them under the Partners organization. They employ their physicians. It's a little bit different model than we have here in Rhode Island. And then secondly, Baylett concluded that could drive costs, as well as something called, it's a little technical, but this component that could be added to cost called a facility fee, which is technical, but suffice it to say, it would add money. And it's not clear in Baylett's conclusion that it really adds value. And in fact, I think Baylett concludes the report by saying, ultimately, it's the states has the most influence on whether the partners and how and if the partners' acquisition of Care New England will add cost to premiums. It's not all that conclusive. There's a couple of places to look. But I think we are trying hard to be part of the conversation in terms of affordability. But as we talked about earlier, premiums are driven by healthcare costs.
So it's going to stay a concern for you.
It's going to stay a concern for us.
I have to ask you about, I've done enough interviews to know people can't usually talk about pending litigation, but I at least have to
Sure.
ask. Blue Cross is in a bit of a legal battle with Steward Healthcare of Mass over this was long before your time, but their attempt to acquire Landmark. Is there anything you can say about your view on where that's going?
Well, I only smile because you won't be surprised to know that I can't really comment on it. I think only to reiterate what we've said publicly, that we're disappointed with the court's decision. We remain confident that we will prevail in the case and that Steward Healthcare's claims are without merit. We take very seriously our mission to provide high-quality, affordable health care to Rhode Islanders.
So I have to ask about your old employer, Aetna, which CVS right here in Rhode Island is trying to buy. Mega deal. CVS, they have minute clinics, they run the pharmacy benefits for people. What do you are you scared of that deal? Do you think it could be? What are you thinking about it, especially having worked at Aetna?
Yeah,
too?
sure. You know what? I say bring it on. We need some innovation and we need some change, and so bring it on. I think that what both CVS and Aetna have said, both their CEOs have said that they want the CVS retail store to be what they call the front door to healthcare, and I say fantastic. Because here in Rhode Island, Blue Cross Blue Shield of Rhode Island has what's called Your Blue Store. And I think
these are your retail outposts.
These are our retail stores where about 70% of Rhode Islanders, little fun fact, live within 10 miles of 10 minutes actually, of a Your Blue store.
Which is the maximum most Rhode Islanders will drive.
Precisely. So, and we have really interesting experience in the several years we've had our stores open. People come to our stores to buy an insurance product, to see a nurse, to get a flu shot, to attend a free fitness class. We had actually a member come into one of our stores a couple of weeks ago and actually met with the nutritionist, and the nutritionist walked the member to a grocery store to help the member understand how to buy groceries for this member's diabetic condition. So we see huge success in these stores. We've seen year-over-year traffic that's been more than doubled. People love it, and it's a broad range of services. As I said a second ago, we have nurses in these stores. And so we have members coming in for services that you would expect, a case or care management consult, and others like that.
Only about 30 seconds left. Could you see that growing into something that directly competes with Minute Clinic?
You know, it's a little bit different, but I actually think it has similar potential value. I actually have said to some of the physicians here in the state of Rhode Island, let's take our Blue Store and let's actually just co-locate in your physician's office so we can help not just in how you deliver care, but make it more effective and efficient and more transparent to the patient or the member, right? Easier to follow, simple, dare I aspire.
As simple as health insurance can ever be. All right, Kim Keck, President and CEO of Blue Cross Blue Shield of Rhode Island, thank you for joining me.
Thank you, Ted.
And thank you as always for joining us. Remember, if you missed any of this episode or any other episode of Executive Suite, you can find all of those on our website. That's at WPRI.com. See you back here next week on Executive Suite.